Hi, this is Duncan Ferguson. In this presentation, what I'd like to do is to talk about a currently held, fairly broadly held, what I'll describe as more or less a myth about the simultaneous use of glucocorticoids and NSAIDs. Now, we'll talk about the evidence behind this. We'll also talk about how the implications of regulations imposed upon drug companies originally may have led to some of this concern. And we'll talk about where there's some truth to this problem, that there's an ulcerogenic potential, for example, of inappropriate and excessive use of glucocorticoids and NSAIDs. And I'm going to talk specifically about the concept of washout. And this is an important concept that's being bandied about with regards to switching between nonsteroidal anti-inflammatory drugs or between glucocorticoids and nonsteroidal anti-inflammatory drugs. And we'll talk about the evidence behind all of this. So the idea is that we're going to talk about whether there's a washout period that's medically justifiable between NSAIDs or between NSAIDs and glucocorticoids. And we'll talk about evidence for the case against washout and the case for it. And then I'll lead to some, what I hope will be practical conclusions and recommendations for the use of these compounds. So let's first talk about the idea of a washout, and I'm calling this a new old wives' tale. And I want to give thanks to Dr. Mark Papich and Duncan Lascelles of NC State University and Steve Budsberg of the University of Georgia for their collective written input about this concept. And you'll see some of their work pop up as we talk about the literature associated with these compounds, particularly the NSAIDs. So what are we talking about? What's the tale? Well, there's promotional material that's published currently by the drug companies that produce nonsteroidal anti-inflammatory drugs that make a statement something like this: consider appropriate washout times when switching from one NSAID to another and when switching from a corticosteroid use to NSAID use. And this link, which is now about 7 years old, but it reflects the times in which there were some great concern about this, actually in the FDA site itself, that said only one brand of NSAID should be administered to a dog at any given time. Okay, that's one statement about whether you can switch from one to another. Don't overlap them. That's for sure, certainly the case. And if the owner and or veterinarian try a different NSAID, then a washout period is recommended. And even the FDA in this case, I'm going to argue, isn't really based upon any tremendous amount of evidence. And they say a washout period is a few days long, during which the dog doesn't receive any NSAID whatsoever. Then the dog can be switched to another NSAID, and that NSAID shouldn't be combined with the use of a corticosteroid either. And this is a separate issue which we'll deal with at the end. But I first want to deal with the NSAID to NSAID switch. And a little history is useful. For basically most of my medical training, we had available to us not too many nonsteroidal anti-inflammatory drugs, and so I got my degree in 1979. And you can see we had aspirin. This is for small animals. And we also had phenylbutazone, but it was mainly used in equine medicine, and meclofenamic acid, which no longer is marketed, so let's forget that. It wasn't until we saw carprofen, and we'll talk about that, and it was approved in 1997. And then along came others, Totolac, the Coxibs, meloxicam, topoxylin, which are different classes of drugs, and Firocoxib. So just to give you some perspective, and everything started with the marketing of carprofen because aspirin has never been approved as a mono product, and no drug company was particularly concerned about its veterinary use. Okay, so first we're going to make about 5 points about this issue. And the first thing I wanted to point out is that the term washout was introduced by pharmaceutical companies and by those that developed some of the first veterinary approved NSAIDs. And I think this was in response to the inevitable side effects that one sees with NSAIDs in this class of drugs, and the sort of rush to move from one type of NSAID to another, or from a glucocorticoid to this new NSAID. So basically what happened after that came from support through the web, basically through the internet. It made its way onto basically approved labels for the FDA in ways that aren't clear to me. And of course, promotions and discussions at conferences without any convincing scientific evidence for support. So where did this all begin, at least in my opinion? It began when we started to see people moving from whatever they were doing for managing inflammation in dogs and cats before 1998, 1997, to the availability of carprofen or Rimadyl. And just so you can put this in perspective, the adverse drug effect reports that the Center for Veterinary Medicine received in 1998, so this is where adverse reports come in from veterinarians, 39% involved the Rimadyl product, which was more than any received for any other animal drug. Of course, for any one of these reports, there's no absolute certainty that the suspected drug caused the effect, but the increase in the association and the suspicion with regards to this drug were interesting because most of the adverse effects described were consistent with those known for NSAIDs. And about 13% of these adverse drug effects involve the death of an animal, either because of the cause of the drug or because of euthanasia. So in a very rapid fashion, as these serious side effects were becoming clear, the Food and Drug Administration Center for Veterinary Medicine began to document these effects and requested that the pharmaceutical company, Pfizer, change the Rimadyl packaging to list the adverse effect reactions. And so they did this in 1997, literally after it had been introduced as a new drug 5 months before. And they created and mailed to veterinarians a Dear Doctor letter, which outlined the latest information available and also made changes to the Rimadyl package insert. So basically, quick response was made by the pharmaceutical company, and veterinarians were notified about this. And so this wonder drug, the first really was felt to be a drug without side effects, with regards to the GI side effects at least, started to become, well, not quite what it was touted to be, but certainly still an important addition to the armamentarium of therapy. So before we go on too much further, I want to take the other side and note that indeed adverse effects of NSAIDs can be serious. And here I describe a study by Lascelles in 2005 that described 29 cases of gastrointestinal perforation following what was felt to be a selective COX-2 inhibitor, and that's daracoxib. And so this was used for a period of time. It was listed for a maximum of 7 days. However, 20 dogs died or were euthanized, and 9 survived with GI perforations. But the problem with this was there was an unclear correlation between daracoxib and the induction, in its administration and the induction of GI ulceration. The statement made by the authors at the end of this paper was that basically daracoxib should be used at approved dosages, and corticosteroids and other NSAIDs should not be administered in close temporal association with daracoxib and possibly with other selective COX-2 inhibitors. So what they were saying is yeah, okay, these drugs aren't, the COX-2 selective, quote unquote, inhibitors were not as selective or as unencumbered by adverse effects as certainly the marketing people hoped for, but they were also trying to point the finger a little bit towards corticosteroids and other NSAIDs that might have been administered at the same time. And so the conclusions became a little bit muddied in this study. Despite all that, basically Deramax, which is the daracoxib trade name, the company produced a Dear Doctor letter that, again, mentioned, many of these cases, side effects may be associated with other drugs. They're pointing the finger somewhere else. And they stated on their original label that all of the veterinary approved NSAIDs, any concomitant administration of anti-inflammatory drugs should be avoided or closely monitored, and observe appropriate washout periods. So you can see this is making it into basically into the package insert for these drugs. And the length will vary. They don't tell you what that is, and it depends on the animal's condition. They don't tell you how to manage that or what other drugs might be most problematic. So it started to permeate the scientific literature, and here's an American Journal of Veterinary Research paper in 2006 that shows basically the actual data from the paper showed no difference was noted between carprofen administration with either oral carprofen or oral daracoxib. So they were comparing these two drugs. Nonetheless, it was stated in the conclusions that in general, veterinarians are advised to discontinue an NSAID for 24 hours to 7 days prior to initiating administration of a second NSAID. Where the paper had no data to support that, and yet it was sort of continued because it was felt to be, the popular thing to think about. Now, I thought I'd take you to here the actual side effects reported to the Center for Veterinary Medicine, the FDA, in 2011 as reported by Booth. And you can see that how many were reported for carprofen, meloxicam, and daracoxib, but they all kind of look the same. There's a lot more vomiting than diarrhea, and then there is an elevation of BUN, indication of kidney disease. So, but these side effects are common amongst all of these drugs, all of which were at some point or another touted to be safer than non-selective drugs for the GI tract because they were selective, quote-unquote, COX-2 inhibitors. Now in point 2, I want to sort of address the issue of the concept of a washout, that there's some time period, this magical time period between which two NSAIDs might be given. First of all, there's no correlation between the safety of a drug and its pharmacokinetic half-life. Basically, half-lives don't correlate in most cases in small animal medicine with the frequency of administration. Most NSAIDs are given once a day, but half-lives vary somewhere between 3 hours for daracoxib to 8 hours for firocoxib and carprofen, and even longer for meloxicam. So the anti-inflammatory and analgesic effects and toxic effects persist longer than the plasma half-lives would predict. So that's an important point. So in this study, the point 3 is that there was a huge study that didn't support a washout time for NSAIDs at all in dogs. And so this study was using firocoxib, and it was administered to dogs after a washout period ranging from 1 to 5 days. And after analyzing 1,000 patients, so it's a very large study, there was no increased risk from switching from another NSAID to firocoxib within 7 days compared to any longer washout period. So the washout period varied between 0 and 7 days, and with most of them more than 2 days. So there was no increased risk, in addition, when switching from one NSAID to another within a week compared to administration of an NSAID without any prior treatment. So basically the concept of washout, even though we know there's prolonged effects of NSAIDs, really doesn't make a lot of sense, at least in terms of the way that term is being used. Okay, now I'd like to turn to a mechanistic reason why we may be seeing different effects of particularly the adverse gastrointestinal effects of some of the drugs in the NSAID class. And it first became apparent that when you selectively inhibit COX-1 or COX-2, you don't get as much gastric damage. Whereas when you give aspirin, so when you give aspirin, it suppresses prostaglandin synthesis from both COX-1 and COX-2, as it's shown here, COX-1 here, leading to basically these beneficial effects, and COX-2 leading to these beneficial effects. And yet, aspirin triggered, in addition, the production of a lipoxin called aspirin trigger lipoxin that partly counteracted the detrimental effects of prostaglandin suppression. So basically, the administration of aspirin, which is a COX-1/2 non-selective inhibitor, led to some of the limitation of the detrimental effects of prostaglandin suppression in the GI tract. Okay, let's take a look at what happens when we use a COX-2 inhibitor. And you can see here that the COX-2 inhibitor will block the production of the aspirin-triggered lipoxin, and so the beneficial effect of that is eliminated. So a selective COX-2 inhibitor removes that benefit. So therefore, the co-administration of aspirin and a selective COX-2 inhibitor results in more gastric damage than induced following administration of either drug alone because of the reduced production of this protective factor. So let's keep that in mind. So let's think about, well, which way were we going? We're going from a non-specific COX inhibitor usually to a more specific COX-2 inhibitor, and any overlap of that period of time would lead to actually more damage. And we know that there's evidence for this ATL in dogs. It was actually shown in old studies that after 1 to 2 weeks of aspirin, GI lesions would resolve despite continued administration. And we had a lot of experience with aspirin at fairly high doses. I remember an orthopedic surgeon saying you give a buffered aspirin for every 10 pounds to an animal that had an arthritis of some sort. And so we didn't see the amount of GI problems that one might expect. And this adaptation to aspirin in this study was touted as being associated with a rise in gastric blood flow, a reduction of inflammatory cell infiltration, and an increase in mucosal cell regeneration. So just the opposite of what you'd expect with regards to the reduction of the beneficial prostaglandins. So actually high doses of aspirin, really high doses, may override the process of this adaptation. So there is a limit to how much aspirin one can give. And so when you started to give that dose that the orthopedic surgeons would tell us to sometimes give to dogs, that adaptation would not occur. So there's a limit. So at lower dosages, you have a chance for this adaptation to occur, but not at higher dosages. So does all of this occur with NSAIDs other than aspirin? Well, the evidence is either insufficient or conflicting. We know that there are GI lesions from administration of daracoxib and carprofen, and that they're worse in the course of treatment on day 2, but they get better by day 5. And on another study on a day 1 of a crossover study, the lesions that were observed despite a 16-day washout time. And sequential NSAID administration may exert long-term effects and require further study. That's basically what was the conclusion of one study, and indeed that was probably true. But we know that this washout time concept was faulty. So evidence for long-term adverse effects after 2 months of treatment were not observed in this final study, and yet there was evidence of adaptation. So this is with non-aspirin drugs. So there is a possibility, likelihood in fact, that the adaptation, maybe through ATL, is occurring with other NSAIDs. But so far the data is insufficient. Now let's turn our attention to a different story, really. It's about the overlapping use of glucocorticoids and NSAIDs. And so here I'd like to point out that, sort of remind you that the phospholipase A2 embedded in the membrane is this enzyme that is producing arachidonic acid that feeds the lipoxygenase pathway and the cyclooxygenase pathway. Now, nonsteroidal drugs only inhibit production of the cyclooxygenases, and therefore thromboxane A2, prostacyclin, and the PG, F2 alpha, and E2. Glucocorticoids block the phospholipase itself, therefore reduce the arachidonic acid feeding through both pathways. And so why is it that we have suppression of immune system? Well, it's because we have the production of leukotrienes and chemotactic lipids that are associated with attracting cells to a site of inflammation. So that's why glucocorticoids are much more powerful than NSAIDs with regards to their anti-inflammatory effects. So it's been called necessary to use a washout period with glucocorticoids and NSAIDs, and I think this gets a little more complex. I'm an endocrine pharmacologist, so I want to point out a few things. The washout time has been called necessary. So this recommendation arises from studies where there was concurrent treatment with an NSAID and glucocorticoids that showed exacerbation of lesions. And there's no question. They act in different ways. You see more gastric lesions with NSAIDs. You see more duodenal and ileal lesions with high doses of glucocorticoids. Now the rub in most of these studies is that they're using really, really high ulcerogenic doses of a very potent glucocorticoid called dexamethasone. And they're also using high doses of flunixin, which isn't itself inherently ulcerogenic. So it's hard to say that there's any possibility of determining a washout time between glucocorticoid and an NSAID, because that just really hasn't been studied. As we'll point out, the issue of washing out a hormone that has been on board at high dosages for a long time leads to endocrine problems, and we'll address that shortly. Let's take a look at one paper that probably is pretty relevant to this question. It's a paper by Boston in 2003 where they looked at endoscopic evaluation of the gastroduodenal mucosa following short-term concurrent administration of meloxicam and dexamethasone. And I already talked about the intrinsic ulcerogenic potential of both of those. So they used 4 treatment groups, treated for 3 days: saline, dexamethasone, meloxicam, or dexamethasone and meloxicam. And they monitored the animal, the typical things, endoscopically, looking for occult blood, looking for anemia through packed cell volume, and then they did the histological exam of the biopsy, as well as a physical exam. And so what they found was that the endoscopic score of dexamethasone and meloxicam was significantly greater than any of the other group scores. But by itself, meloxicam seemed to be fairly safe on the GI tract, similar to the saline group. And dexamethasone caused GI lesions, and the effect was significantly increased with the addition of meloxicam. So that gets to the point of saying, well, dexamethasone has a problem by itself at this high dose, fairly high dose, and meloxicam not so much, but together they seem to magnify each other. So clearly we are looking at a problem when you simultaneously administer these drugs. Let's look at another study that was done in 2007, studying the effect of nonsteroidal anti-inflammatory drugs and prednisolone in healthy dogs. And here they were given for 30 days either meloxicam and prednisolone or ketoprofen and prednisolone. And so they did similar things as the previous study, and they graded the endoscopic lesions, looked at fecal occult blood, and it was, they found more severe impact endoscopy and fecal occult blood in the ketoprofen group with prednisolone. And they had clinical signs of anorexia, vomiting, diarrhea, or melena. The meloxicam group had developed few invasive erosions, and there was no significant difference between the dogs with meloxicam prednisolone and those that were controls. So the ketoprofen and prednisolone group also showed some impact on the kidneys as well as the GI tract. So the point here is that even in healthy dogs, concurrent administration of NSAIDs with glucocorticoids may be contraindicated, even if the NSAID is COX-2 selective. Now, we've already learned about the problems with COX-2 quote-unquote selective drugs, so this shouldn't be too much of a surprise to you. Okay, as an endocrine pharmacologist, I want to remind you that the advice to, let's say, take an animal from glucocorticoids and just take them off is inadvisable. And so basically you don't want to wash out glucocorticoids, they say. You want to slowly wean them off, and we talk about this in the glucocorticoid presentation. And I'd also note that for many years, even though aspirin itself was not a monodrug approved for the dog, there is a combination product that exists made by Pfizer that's methylprednisolone and aspirin. And so this has been approved and is used simultaneously. Now they're relatively low dosages. So when you decide to remove an animal from glucocorticoids, you have to consider the hypothalamic pituitary adrenal suppressive action of glucocorticoids. And just remember, wean, don't wash out cold turkey. So let's deal with the issue of the washout or withdrawal time. And this came from a website that I found on a practice specialty center, and they listed NSAIDs and also glucocorticoids and their names and the withdrawal time. And my question is, up here at the top, where did these numbers come from? There's really nothing in the literature that would support any of these numbers from the standpoint of what withdrawal time would be appropriate between giving glucocorticoids. In fact, we know that it kind of depends on whether you're going between aspirin and something else, or something else that's maybe not a COX-1, COX-2 non-specific drug to a more specific COX-2 inhibitor. So these numbers, I'm sorry, they don't exist in the literature anywhere that I can find. So how does this all fit together, and what would be the conclusions based upon the best evidence? If you have a COX-2 inhibiting drug, so that's a COX-2 inhibiting drug, and you have an animal that has gastroduodenal injury or has an ulcer already, there has to be an increased risk of delayed healing and further injury because of starting another drug. So really what we're talking about is the logic should be around whether there's pathology in that animal or not, as to whether you should just pile on some more NSAID in that situation. Most would agree that washout following aspirin is a unique situation, and this is due to the idea of aspirin-triggered lipoxin, in which case you are actually inhibiting the beneficial effects that had been developed for the GI tract when aspirin by itself was given, when you all of a sudden give a COX-2 inhibitor. So that movement from aspirin to others is to be considered perhaps more cautiously. And washouts between NSAIDs is a poorly researched area and requires further evaluations, but probably somewhere between 5 and 7 days following aspirin is probably about right based upon the studies we have available. So recommendations would be, it is rational to consider rotating drugs to manage inflammation and pain in order to optimize therapy. So let's ask the question, is the reason that you're changing from one to the other a lack of efficacy and not intolerance to the drug? Then, of course, if it's a lack of efficacy, the lack of good effects probably parallel the lack of bad effects, and washout would be less of an issue. If you've already got adverse effects, the washout time should allow recovery from those adverse effects. And extra caution seems appropriate when switching between a COX-2 nonspecific inhibitor or glucocorticoid and a COX-2 inhibitor. Don't forget about the endocrine effects of glucocorticoids and wean the animal from glucocorticoids and not just take them off rapidly. Anytime you have greater need for serious pain management and inflammation management, you may want to consider other agents like gabapentin, fentanyl, codeine, and tramadol, primarily when you're trying to manage more serious pain. So that's my take on the issue of washout, either between NSAIDs or between the glucocorticoids and NSAIDs. And hopefully you've seen here a little bit of evidence-based therapy at play as we talk about what it could be sort of a knee-jerk reaction to say never about administering one NSAID and then another without really thinking about why you're saying that or where the evidence for that is, because a lot of it gets picked up by popular media, the web, even CE conferences. So we have to be a little bit careful about what conclusions we come to and re-examine the primary literature as I did here.